on complex nursing situations, particularly stroke treatment. The brain is a complex, integrative organ in the neurological system that influences all the other systems in the human body. Assessing and caring for a patient with a neurological problem is complex and requires in-depth assessment. The patient will require critical care management. The nurse is more equipped if he or she understands the neurological disease in its entirety. With that being said, what is stroke? A stroke may be defined as a neurological deficit that has a sudden onset, results in permanent damage to the brain, and is influenced by cerebrovascular disease.
So there are two classifications of stroke. There's ischemic stroke and there's hemorrhagic strokes. So with ischemic strokes, there are a blockage of blood vessels, and this prevents blood flow to the brain. And with hemorrhagic stroke, there's a rupture of blood vessels, and this causes bleeding within the brain. So what causes strokes? Strokes are caused by an interruption in blood flow to the brain, and this can happen due to large artery thrombosis, which can be caused from atherosclerotic plaque buildup, or it can be caused from a cardiac emboli, which are associated with cardiac dysrhythmias.
Hi, I'm student nurse Kay Johnson, and I'll be presenting on the clinical map part of our presentation. So here, our patient, Mr. KH, is a 36-year-old male patient. He was admitted on the 22nd of February 2020. His admitted diagnosis is left penetrating neck and face wound, left CVA, and right hemopararesis. He was found unconscious on the 22nd of February 2020 with a broken glass object stabbed into his neck. He was then taken to hospital via EMS and with an unstable O2. On the date of admission, which was the 22nd of February 2020, Mr. KH had an ear, nose, and throat review and was intubated. Ventilation settings was SIMV IO2 30%, rate 12 beats per minute, a tidal wave of 498, pressure control of 10, and pressure support of 10. He also had exploratory of left anterior triangle of neck, partial parendectomy, repair of left facial artery, and vein repair of vagus nerve. On February 23, 2020, Mr. KH had a CT scan of the brain done, which showed that there was a cytotoxic edema present. However, on the 24th of February 2020, there was shown that there were more cytotoxic edema, and it was shifted midline to the right, measuring 8.5 millimeters. There was no acute bleeds, and his bones were shown normal. He also had decompressive craniectomy and a family conference scheduled that day. On the 25th of February 2020, Mr. KH had his neurological status assessed, which showed that he had a Glasgow-Coma scale reading of 5 out of 15. On the 26th of February 2020, he was scheduled to have a tracheostomy and a PEG placement. Following 2 days after, which was scheduled to have his tracheostomy and PEG placement done, Mr. KH had his trach and PEG placement on the 28th of February 2020. Mr. KH's health started to deteriorate very rapidly. From our analysis, we may say that the delay of his CT scan may have contributed to the deterioration of his health. This is because he never received a CT scan until the second day of admission, whereas an unconscious patient is to receive a CT scan within 45 minutes of hospital's evaluation.
Hi, my name is student nurse Mcdonald, and I'll be speaking about drug interpretation. The goal treatment for stroke is to commence it 3 hours after onset. Mr. K's initial drug order goes as follows: Pepsid, 20 milligrams IV once daily, phenobarbital, 60 milligrams twice a day per oral, Clexane, 40 milligrams subcut once daily, minocycline, 100 milligrams twice a day per oral, cefazolin 1 gram IV every 8 hours, and morphine 2 to 4 milligrams IV every 4 hours. The patient's recent drug order goes as follows: mannitol 20%, 250 cc's twice daily, Clexane 40 milligrams subcut once daily, Colace 100 milligrams twice daily per oral, Panadol 1 gram every 8 hours or as needed for temperature 100.4 or greater. Phenobarbital 60 milligrams 3 times a day per oral, Pepsid 20 milligrams twice a day IV, and Baralgin 1 gram every 8 hours or as needed IV. Pepsid, which is a histamine 2 antagonist, is used to decrease symptoms of gastric reflux. The action of Pepsid is to block the action of histamine in the parietal cells, ultimately blocking acid secretions in the stomach. This medication, when given IV, prevents and treats stress-induced upper GI bleeds. In the case of our patient, Pepsid is used to treat symptoms associated with gastric stasis. Minocycline. Minocycline is a tetracycline anti-infective that inhibits the growth of bacteria. This is a broad-spectrum antibiotic which is used as a preventative measure as a result of trauma, open wounds, which would attack a wide range of bacteria. Its beneficial effect for stroke is related to its anti-inflammatory and neuroprotective action. Phenobarbital. Phenobarbital is an anticonvulsant which is used for anticonvulsant activity or sedation. This drug acts as a CNS depressor and inhibits transmission in the nervous system and raises the seizure threshold. In this case, this drug was used as a sedation for the patient to prevent further damage in the brain. Cefazolin. Cefazolin is a first-generation cephalosporin anti-infective that is used to treat infections. This drug is used to kill bacteria that invades the body through breaks in the skin. In this case, patient KH has a wound to the face which poses risk for infection. Clexane. Clexane is an anticoagulant or antithrombotic drug which is used to prevent deep vein thrombosis, pulmonary embolism, or venous thromboembolism. In this case, this patient has impaired mobility due to being unconscious, and being bedridden leaves him open to forming traveling blood clots. Mannitol. Mannitol is an osmotic diuretic which is used for the inhibiting reabsorption of water and electrolytes. This drug also assists in the mobilization of excess fluid in oliguric renal failure or edema. In this case, the patient has injury to the head causing intracranial pressure as well as cerebral edema. This drug would help to reduce the amount of edema. Colace. Colace is a laxative which is used to prevent constipation by softening stools. This patient has damage to the brain, specifically the vagus nerves, which is responsible for digestive processes. Because colace softens stool, it in turn decreases straining, which can increase intracranial pressure. Baralgin. Baralgin is an antipyretic which is used to treat pain, spasm relief, and fever relief. The action of this drug is to inhibit the synthesis of prostaglandins that may serve as mediators of pain and fever, primarily in the CNS. In this case, the patient was prescribed this drug to treat and relieve fever.
My name is student nurse Curtis, and I'll be discussing the types of diagnostic tests done on a patient experiencing a stroke. The first one is going to be a CT scan, also known as a computerized tomography. This is a series of x-rays to create a detailed image of the brain. A CT scan can show bleeding in the brain, a tumor, an ischemic stroke, or the difference between the non-muscular and cerebrovascular lesion to give the patient the correct treatment. Each had a CT done, which indicated that cytostic edema was present in the brain. MRI, magnetic resonance imaging. This makes a detailed image of the brain to determine the type of damage done and identify areas of ischemia, infraction, and cerebral swelling. Cerebral angiograph. This is an X-ray test where contrast is placed in the bloodstream to produce a clear image of the brain. to show any abnormalities and blocks that indicate strokes. Doppler ultrasound. This test is used to check the carotid arteries on both sides of the neck for blockages. Last but not least, echocardiogram. This is used to detect dysrhythmias or cardiac ischemia. This test can also find clots in the part that travels and causes strokes.
In addition to the patient history, physical examination, and imaging tests, we know that laboratory tests are important in diagnosing stroke. While labs alone cannot diagnose stroke, it is important because it helps us to determine the cause of a stroke as well as other conditions that may be mimicking a stroke. Today, we'll be discussing the lab results of our patient, Mr. KH, as well as reviewing important lab test areas in stroke. Putting his lab results on the screen, and we'll start off with white blood cells. The normal range is 5 to 10 kilo per microliter, and his white blood cell levels are high because it is an inflammatory response taking place in his body. High white blood cell count may indicate that the immune system is working to destroy an infection. And so because foreign bodies were introduced into the patient's body, the white blood cell count is high. In addition to that, he had surgeries done, so the inflammatory response would be the body producing high white blood cells. Now, red blood cell, the normal for males is 4.7 to 6.1, and we can see that his red blood cell level was decreased. This is mainly due to the patient losing blood, HGB 14 to 18 grams per deciliter, and then we have HCT, which is 42 to 52%. Now, with this particular patient, he had a stab wound to the neck, and so he would have lost a significant amount of blood. With that blood being lost, there is a decrease in red blood cells, and as a result, there is a decrease in hemoglobin and HCT. Hematocrit and hemoglobin are reflective of RBC levels. MCV, mean corpuscular volume, which is the average size of RBC, and MCH, the mean corpuscular hemoglobin, is noted to be caused by macrocytic anemia, a complication of infection. MPV, mean platelet volume. Now we can see that the patient's platelets were actually pretty okay, with the normal being 150 to 400, but it's important to note that if a patient has a low platelet count and a high MPV level, it suggests that bone marrow is rapidly producing platelets. So as older platelets are being destroyed, the bone marrow is trying to compensate. Now going back to MCV, the normal is 80 to 96 femoliters. With MCH, the normal is 27 to 31. So all of these complete blood count areas are important to analyze in any patient. Now let's see what Mr. KH's renal profile looks like. I will insert his labs right here. Alright, so renal profile. Electrolytes out of whack may indicate that kidneys are out of whack, which can predispose you to ischemia. And the first renal profile area we're going to look at is glucose. Now, low glucose is hypoglycemia, and some of the clinical manifestations of hypoglycemia include weakness, numbness, vision changes, and speech difficulties. Does that sound familiar to you? It should. And this is why lab results, particularly the renal profile, is important, because it will help you to rule out if the patient is just presenting with hypoglycemia. And it can also help you to determine if the patient is diabetic as well. So what else can the renal profile tell us? Well, renal profile allows us to look for the general condition of the patient. If we look at sodium and potassium levels, we'd be able to see if the patient is dehydrated. When we look at BUN and creatinine levels and look at their ratios to each other, we'd also be able to see if the patient has kidney malfunction. Now, in terms of normal ranges, the normal sodium is 135 to 145, normal potassium 3.5 to 4.5, and in terms of that, the patient has hypernatremia as well as one episode of hyponatremia, but there's nothing alarming with the patient's sodium and potassium. With the patient's BUN, normal BUN is 7 to 20 milligrams per deciliter, and the normal creatinine is about 0.6 to 1.2. So the patient's creatinine levels, which is a determinant for kidney failure, does not suggest that the patient has a kidney problem. Coagulation studies. PT, prothrombin time, evaluates ability to clot. INR, International Normalized Ratio, ensures that results from a PT test are the same from one lab to another, and partial thromboplastin time, PTT, determines if blood thinning therapy is effective. Okay, so on the 23rd of February, our patient, Mr. KH, had a PT of 10.6 seconds, a PTT of 24.3 seconds, and an INR of 1.0. We can see the normal ranges here as well. PT is 10 to 12. PTT, please make a correction, it's 25 to 35 seconds. And with the INR, it's 1 to 2. Based on this, none of the patient's results of the coagulation studies are alarming. LDH was 603 unit liters. GGT was 272 unit liters, AST 118 unit liters, ALT 171 unit liters, ALK phosphatase 222 unit liters. All of these results are extremely high and are elevated. The blood tests showing these elevated liver enzymes indicate that the liver is inflamed or damaged. One interesting study that we found done in 2005 actually indicates that elevated AST levels are predictors for intracranial hemorrhages.
Good day, my name is Fils-aime, and for this particular portion of the video, I will be highlighting medical management of stroke. I will be talking about ischemic stroke, which occurred within our patient. Now, ischemic stroke occurs when an artery in the brain becomes blocked. This type of stroke accounts for 80 to 85% of most stroke cases, which is basically the majority. To medically manage this type of stroke, we want to start with giving TPA. And TPA stands for tissue plasminogen activator. And to summarize it, it's basically a clot buster. This clot buster has to be given within 4.5 hours of the onset of the stroke. If it's not given within this time frame, it basically won't help and it can be harmful essentially. So you want to make sure that the patient receives the TPA within 4.5 hours. The goal of TPA is to reverse or to minimize the effect of the ischemic stroke that has taken place within the patient. The recommended dose of TPA is 0.9 milligrams per kilogram infused over 60 minutes with 10% of total dose being administered as an initial intravenous bolus over 1 minute. And this is for acute ischemic stroke. Now, subsequent therapy with anticoagulants and antiplatelet agents is not recommended until 24 hours after the initial start of TPA. In addition, another medical management of ischemic stroke is airway protection and ventilatory assistance. This type of assistance is done to ensure that the patient has adequate tissue oxygenation. Moreover, treatment of acute ischemic complications such as seizure activity and cerebral edema is also vital to ensure that the patient has good health. For seizure activity, you want to ensure that they are receiving anticonvulsants such as phenobarbital, 60 milligrams, twice daily. For cerebral edema, in severe cases, a decompressive craniectomy is performed, and this is basically a surgical procedure. And this is done to remove a portion of the brain. So it basically allows the brain room to swell without being squeezed. And another medication to reduce swelling is mannitol, and the dosage of this is 1.5 to 2 grams per kilogram, and this is given to the patient to reduce cerebral edema. Lastly, deep vein thrombosis prophylaxis should be initiated to decrease the risk of the patient developing pulmonary embolism. Now, our patient, he had 2 compressive stockings on his feet, both of his feet, and this is to ensure that he didn't develop a pulmonary embolism.
Assessment and care for a patient with neurological problem constitutes one of the biggest challenges for critical care nurses because of its depth and complexity. Gathering patient history is a part of the assessment process. The nurse evaluates past medical history, family history, and surgical history. A comprehensive review of systems is also performed. The physical examination includes mental status and motor function. Mental status includes tests to evaluate level of consciousness and arousal, orientation to the environment, and thought content. In instances of suspect brain injury, the Glasgow-Coma scale is a tool for assessing patient arousal and level of consciousness. This scale assesses 3 different areas such as eye-opening response, best verbal response, and best motor response. Patients can be alert, awake, lethargic, semi-comatose, and in our case, our patient is comatose. Motor function evaluates response to stimuli and motor strength and coordination. Our patient has right-sided hemiparesis, and this is because he has a left CVA.
Another part of the physical assessment is testing pupillary response, which is size and shape. Pupil reactivity is also assessed with respect to light and accommodation. Normal response is PERLA, which stands for pupils equal, round, reactive to light and accommodation. Vital signs are also assessed in a stroke patient. Changes in temperature, heart rate, and blood pressure are considered late findings in neurological deterioration. Changes in respiration are also important, as this may determine a variety of conditions for the patient. Cranial nerve performance should also be assessed. Assessment of cranial nerves in an unconscious patient is important because it provides data regarding brainstem function. Reflexes are another part of the physical assessment. Reflex occurs when a sensory stimulus evokes a motor response. Cerebral control and consciousness are not required for a reflex to occur. Other areas of physical examination are sensation and inspecting the body. Increased intracranial pressure is manifested by deterioration in all aspects of neurological functioning. Loss of consciousness decreases and motor function declines as intracranial pressure rises.
In assessing a stroke patient, you can use the acronym FAST. F, facial droop on one side. A, arm lifting or arm weakness. S, speech impairment. T, time of onset or time to call 911. With left-sided stroke, presentation includes aphasia, inability to speak or understand spoken words. Left-sided stroke may affect swallowing on either side. Left lateral gaze, right visual field deficit, right hemiparesis, or right hemisensory loss. Right-sided stroke affects right lateral gaze, left visual field defects, left hemiparesis, unaware of defects, and nonverbal memory impaired. Our patient is a special case of stroke because he does not fit the standard criteria as a patient with sudden onset stroke. Our patient's CVA was secondary and masked by his presentation to the emergency room for a stab wound. The RAS score. The Richmond Agitation and Sedation Scale. This method is used in ICU to assess the level of sedation in patients. This should be done every 2 hours. Our patient has a score of -5.
So the aim of the nurse's therapeutic management should always be for preventative measures. You want to prevent any complications that are associated with the stroke. So you want to prevent immobility, hemiparesis, or any other neurological deficit that is associated with that stroke. There are several areas that we want to focus on in terms of providing care for the patient, and these include oxygenation and ventilation, circulation and perfusion, neurological, fluid and electrolytes, skin integrity, as well as mobility and safety. Okay, student nurse Leary, can you tell us about the very first priority area of interventions that will be taken for our stroke patient? This area is oxygenation and ventilation. Tell us about that.
Important because we want to make sure that the patient oxygen saturations are within the normal limits. We want to prevent atelectasis, and we want to make sure the patient airway is clear to facilitate the oxygen into the patient's blood system.
Okay, so what are some nursing interventions that we can do to meet the oxygenation and ventilation needs of a stroke patient?
We can make sure that the patient is receiving adequate oxygenation by monitoring breath sounds every shift. We want to check the patient's oxygen saturation every hour, and we want to assist with the removal of secretion since the patient is on a mechanical ventilator. Therefore, we want to make sure that we want to monitor the patient's ventilator settings as well to make sure the patient is receiving adequate ventilation and oxygenation.
Thank you. What can we do about circulation in our patients, circulation and perfusion? Tell us a little bit about that.
This is important because studies have shown that patients who would have experienced a hemorrhagic stroke, 50% of them would experience dysrhythmias. So we're going to hopefully prevent those by doing the following interventions. Firstly, you would want to monitor the patient's vital signs every hour. You're going to look closely at their blood pressure specifically and look for sharp drops, which can lead to hypertension. And this is important to monitor because these can lead to ischemic events as a result of secondary to hypertension. Secondly, it's actually important that cardiac monitoring is happening, and we want to check the patient's cardiac monitor every hour, and we're going to look for signs of dysrhythmias. Secondly, we want to conduct continuous assessment of early signs of low tissue perfusion, which can lead to dysrhythmias. So this would be making sure you're checking the patient's peripheral pulses and assessing their skins for signs of low tissue perfusion, signs of cyanosis specifically, and you can even see edema happening because of venous stasis. So we want to conduct those assessments every shift to make sure that adequate perfusion is happening.
Fluids and electrolytes. The rationale behind fluid and electrolytes is to ensure electrolytes are within normal ranges. So that means you'll monitor the patient's lab results, especially glucose levels, and you'll also monitor the patient's input and output. Skin integrity. The rationale behind skin integrity is to ensure the patient's skin is intact. So you'll perform skin assessments using the Bryden scale. You'll also provide Ripple mattress for the patient, as well as you'll turn the patient and reposition the patient every 2 hours.
Neurological. We want to ensure that the patient's level of consciousness is monitored, as well as ensure that adequate perfusion pressure is maintained. Some interventions would be to perform neurological assessments to monitor for the development of additional deficits. Some neurological assessments would be to perform a Glasgow Coma Scale. If there is a change in mental status, it must be reported to the doctor so that the patient can be reviewed and assessed. You can also check pupillary response, as well as position the head of the bed to 30 degrees in order to promote venous return.
It's student nurse Julia Leary, and on this segment, we'll be discussing the nursing educational aspect of this case. So there are three main areas that the teaching is going to be targeted towards. That will be managing the patient's current deficits, managing the patient's nutrition, and teaching family coping. So specifically for managing deficits, we're going to be managing the patient's impaired mobility. The patient is bedridden, so the caregiver should be taught the importance of positioning. And positioning is important because it prevents skin breakdown, it relieves pressures, it prevents contractures, and it also helps to give the patient proper body alignment. And this is seen to, like I said, to relieve pressure. Similarly, the caregiver should be taught the importance of daily skin assessments. The caregiver should be taught to look closely on the body, especially during bed baths or for any signs of skin breakdown. And this can help prevent infection. And we want to specifically let the caregiver know to make sure monitor those bony areas and those dependent body parts because they are more prone for developing skin breakdown and ulcers. Similarly, we need to teach the caregiver the importance of elevating the legs. And elevating the legs is important because it helps to prevent edema and the formation of thrombus, which leads to DVT. So similarly, we want to teach the caregiver to perform passive range of motion exercises, and this helps to prevent DVTs, and it helps to prevent venous stasis, and it also helps to maintain joint mobility. So for nutrition, it's important that to teach the staff as well as the caregiver the exact techniques for peg feeds, and the patient and the nurse should be taught to monitor for gastric stasis because there have been reports of gastric stasis. We want to continuously monitoring that. And how you would monitor for gastric stasis is that you can aspirate 4 hours after feeds to check to see if stomach contents. You would aspirate with a syringe, and you can check that. And this is important because we know that the patient has experienced damage to the vagus nerve or cranial nerve X, which is responsible for digestive processes. So it's important that we actually make sure that the patient is absorbing those nutrients, and that's going to help to ensure that he is receiving adequate nutrition. Intervention that the nurse can take on is monitoring the patient's albumin levels because this can indicate if malnutrition is happening as well as dehydration. And so the caregiver should be taught that the complications of gastric stasis include severe dehydration. So they can be taught to look for signs of dehydration, basically looking at the skin and monitoring the skin for signs of dehydration. Another intervention that can be taught to both the caregiver and the nurse is to monitor daily weights. And monitoring daily weights is a great indicator of the patient's current nutritional status. So the weights should be recorded and monitored. Now, the nurse as well as the caregiver should be taught the caloric breakdown of the feeds. The patient is currently on 70, 80 cc's per hour. And if you look in the table to the right here, there is an exact breakdown of all of the macronutrients that is in the gevity. And the gevity contains approximately 1.2 caloric intake. And we also want to teach the importance of giving free water, and we want to ensure that the adequate adult nutritional calculation is done based on the patient weight and the caloric requirement based on the patient's BMI. The caregiver of the client should also know the importance of GI feeding. It's important that they know how to check for two position prior to feeding, and you want to teach them the importance of administering the feed slowly and monitoring for non-retained food, like I would have spoken about. Teaching family coping skills are going to be important teaching aspect. The patient's family and their relatives have basically seen their relative decline from a fully independent male to dependent male. So you want to teach them coping skills. As a nurse, you would want to make sure that counseling and support is given to the patient's relatives. The caregivers and the relatives should be taught stress management techniques, and it's important to teach them and to highlight the importance of maintaining personal health, because it's hard for one to actually give support to the client, to each other if they're not attending to their own personal health. Similarly, you want to make sure that the patient's family is fully involved in the management, and this would help them to cope.
Now let's review the clinical management of Mr. K. Some of the needs identified include ventilation. The patient has ineffective airway clearance, and this is related to the trach obstruction and the secretions. Mobility. Patient has impaired physical mobility. The patient has impaired skin integrity, imbalanced nutrition, and the psychosocial need specifically toward the family must be met as well. If we are to go into the hospital on any given shift to provide care for Mr. K based on the information that would have been provided throughout this presentation already, what would be the plan of care? The first thing we're going to do is assess our patient. We want to assess the patient's level of consciousness. Of course, Mr. K is comatose. We also want to assess the patient's airway. Mr. K is breathing on mechanical ventilator via trachea, and we also want to check his vent settings as well, being sure to monitor his PEEP, his FiO2, and we also want to look at his oxygen saturation. We must conduct a complete head-to-toe assessment of Mr. K. We want to inspect, palpate, and auscultate our patient, looking specifically for any complications that may be occurring with our patient. We want to look for signs of edema, any signs of skin breakdown. We want to make sure that we completely assess our patient and that we don't miss anything. Level of mobility is also assessed. We know Mr. K is bedridden, and in his comatose state, he is unable to move. He also has right-sided hemiparesis. We want to look for sites of impaired tissue integrity, paying attention to the sites of surgical incision, his trach, and we know that he is more susceptible and at risk for impaired tissue integrity because he is unable to move. We want to assess his vital signs. We also want to know that the patient has an 18 French Foley catheter in, so cath care must be done in addition to meeting the patient's hygienic needs. Dependent nursing. First thing we do, check the doctor's orders. We want to check vital signs as per ICU protocol every 2 hours and administer medication prescribed by the doctor. The medications Mr. K is on would have been covered already. Commence fluid therapy and monitor intake and output. Mr. K is on 0.9% normal saline at 20 cc's an hour, so we want to monitor that. We also want to provide TPN diet. Mr. K is on Chevity 80 cc's an hour. Therapeutic nursing involves suctioning the patient as needed and taking extreme caution when doing so. Provide tissue care as needed. Turn the patient every 2 hours. You also want to position the patient in lateral or semi-prone position as this promotes the drainage of secretions. Execute passive assistive range of motion exercises. We want our patient to maintain muscle strength. Elevate the head of the bed 30 degrees, and this is to promote venous return as well as decrease the buildup of intracranial pressure. We also want to ensure that the nutritional needs are being met. In our patient's case, his daily caloric intake was not meeting up to the standard of his recommended daily caloric intake. So we must consult the doctor so that the amendments could be made in his orders. Evaluate labs. And of course, lab interpretation would have been done already. We already know which labs we want to look for specifically. Compression stockings. Mr. K has compression stockings on both of his feet. Ripple mattress. This is also for pressure care. Collaborative. The doctor. You want to make sure that you are connected with all teams that are connected to the patient. Surgical, neuro, medical. You want to connect with the physiotherapists and spiritual advisors. Education is also extremely important. And of course, you cannot educate the patient himself because of the state that he's in. But it is necessary to educate his family. So you want to teach them on stroke and the patient's condition and coping skills.
It's nursing student Juliana again, and we're back in the studio. In this segment, we'll be talking about current trends. So these current trend tools and equipments are basically used to facilitate the recovery of patients who would have experienced a stroke, or it's been used as a diagnostic tool in the healthcare industry for detecting strokes. So the first tool that we'll be talking about is the cone beam imaging. And this new technology tool is being highlighted for its ability to detect hemorrhages, occlusion site, ischemic scores, and at-risk tissues. And it's being highlighted because it basically is able to detect strokes in a very timely fashion. And we know that with stroke, time is an important factor, and we don't have much of it to lose. The second tool that we'll be talking about is the Cerebrotech Stroke Detecting Visor, and this tool is also a diagnostic tool. And what it does, it is able to recognize emerging large vessels that could be possibly occluded in patients, and it also detects blockages. And this tool is basically used for patients who would have been identified for being at risk for stroke. And it basically does this through low energy radio waves. So the third tool that we'll be talking about is the Vivastim nerve stimulation treatment. And basically this is a tool that helps patients who would have had strokes to recover. And basically this device is able to help provide muscle movement therapy through vagus nerve stimulation. And basically this leads to the strengthening of the neural circuit in the brain, which is responsible for motor function. So the last tool that we'll be talking about is the Raphael Smart Glove, and it's literally a glove that goes on your hand, and basically it follows hand motion with bending sensors and an accelerometer. And so while you're performing exercise, it is able to give you positive feedback to let you know if you're not doing the exercise correct. And so basically this also helps to improve your motor skills. And these are 4 new current trending tools or new trending technology in the healthcare industry that is facilitated towards helping improving how we diagnose and treat strokes.
When a patient is brought into the emergency with symptoms of stroke, the door to admission time should be no more than 3 hours. If appropriate, the fibrinolytic or thrombolysis treatment should be initiated within 1 hour of arrival at the hospital. 4 departments are involved when administrating the stroke protocol. 1. Emergency. 2. Neurology. 3. Radiology. 4. NICU.
Pulse and blood pressure. Check airway assessment.
Assess airway and evaluate vital signs.
I want one ECG, Rinku, as well.
Establish vascular access. Send blood for appropriate lab testing. Review the patient's history, including past medical history.
पहले से कोई बीमारी तो नहीं है?
हाँ, पहले इनको हार्ट प्रॉब्लम है।
अच्छा, हार्ट प्रॉब्लम है।
Perform a physical exam and establish last known normal.
सर अपनी आंखें बंद करो जोर से, खोलो. Okay. So this is your left side weakness and it's 30 minutes time 0.
Can you please announce code fast?
Yes, ma'am, I'll do that. Hello, I'm Dr. Farah calling from emergency. Please announce code fast.
Hi, Dr. Jyoti.
Hi,
We've got this 50-year-old man who has come with acute stroke.
Okay.
He's got left-sided weakness
Okay.
And he's got it since last 30 minutes. So
Since
time
last
0
30
is 30 minutes.
Okay. He's not hypertensive diabetic?
He's got a heart cardiac history, but no other medical history, or he's not on any medication.
No anticoagulation?
No.
All right.
Perform a neurological exam to assess patient status using the NIHSS or the Canadian Neurological Scale.
आप ये पढ़ सकते हैं जो ये लिखा हुआ है? Six.
Sapria 1 ma'am, and the motor arm for 2. Total analysis is ma'am 8.
8. So we can thrombolize him, shift him for CT scan.
Order a CT scan of the brain or MRI within 25 minutes from the patient's arrival in the ER. Within 45 minutes of the patient's arrival, based on the CT scan or MRI, determine whether the stroke was ischemic or if a hemorrhage is present. If the stroke is ischemic, the decision to administer a thrombolysis or fibrinolytic injection is made after the consent of the patient and the family.
इंजेक्शन हम किसी को देते नहीं. आप अच्छे से पढ़ लीजिए, पढ़ के देख लीजिए, जब तक फिर उसको साइन कर दीजिए, तब भी हम आगे दे पाएंगे.
The nurse gives the injection on the ER doctor's mandate. The patient then gets transferred to NICU. If a hemorrhage is present, note that the patient is not a candidate for the thrombolysis or fibrinolytics. Move patient to NICU and arrange for a consultation by a neurologist or neurosurgeon. If required, prepare for surgery.
Good morning, Mr. Anil. Yeah, I'm Dr. Atampreet from neurology. Yesterday you had a stroke?
Remember, as soon as the hospital hears of a patient demonstrating stroke symptoms arriving in the ER, begin the stroke protocol and have all 4 departments ready.
Those tests will be done today and tomorrow, and after that we can discharge you.